very much. Thank you very much. Assalamu alaikum. Thank you very much to Dr. Yogesh and the organizing committee for asking me to speak. This is a very great conference, and congratulations to you, Dr. Yogesh, on putting on this prestigious conference here in Abu Dhabi. We've been having a potpourri of different kinds of topics. Most of them have been top heavy on interventional endoscopy and EUS and ERCP. And I've gone to the other end of the spectrum here, looking at a little bit about what we do on our day-to-day basis in terms of clinical GI examination in the era of teleconsultation. So today I'm just going to zip through a few slides to try to give you some idea about what's going on in this area. So we'll talk about the physical examination. We'll talk a little bit about telehealth and telemedicine, compare and contrast some of these pros and cons, and demonstrate why the physical exam is probably in its death throes. I mean, this kind of question up here generates many questions, but I will just put some of them up. What is a clinical GI exam? What is lost when the doctor and the patient are not together in the same room? What is gained by teleconsultation? What is the purpose of the clinical GI exam? What do patients want? What do doctors want? What do payers want? Have healthcare outcomes improved with teleconsultation? We'll answer some of these things. What is the future of GI evaluation? We'll address this a little bit. And what's the role of AI in GI examination? So obviously, when we're looking at the human body, this is from the Institute of Plastination, the body is a very complex thing. You could be married to your wife for 20 or 30 years and you still don't know who she is. And inside the body, these are the various organs packed in there. And as a doctor, we have to try, as part of our things in terms of the history and the physical examination and investigations, many doctors have historically been focusing on the physical examination. Why is that? Because when we went to medical school, we 10, 15, 20 years ago, the triad of investigation is the history, which accounts for approximately 70 to 80% of the information, the physical examination, where you're supposed to collect a little bit more data, and then subsequently the investigations. But when you look at the human body, which is in fact a black box, when we think about it, we don't know what's in it. Our main aim as doctors is to collect data. And we collect the data by history, examination, and investigations. History, examination, and investigations. Thereby, but when you do the examination is really focused on the general examination, a focused GI examination, for example, signs of chronic liver disease like stigmata, and examination of other elements of the GI system, including the teeth, the tongue, skin, abdomen, perianal area, if indicated constitutional features. Now, when we move from exam to investigations, I'm just taking you back to before many of you were born, but long ago, about 50 years ago, people used to do stool gazing. So in Massachusetts, in Boston, when I was there, I saw many pots of Burra's stool in Harvard Medical School, and the doctors in the 1950s, including Franz J. Ingelfinger, who is perhaps the most famous gastroenterologist in the history of gastroenterology, used to spend a lot of time looking at the quality of the stool to decide on the diagnosis of the patient. Then in the 19th century, there was phrenology, where you examine the head and the shape and the contour of the skull to try to decide whether people have problems. And obviously going back beyond Greek medicine, we have the four humors that people used to look at, like phlegm, bile, other things like that. And then some people, you know, in the 19th century used to look deep into the eyes to see if they could discern different kinds of diseases. I'm not talking about Kayser-Fleischer rings. I'm talking about diagnosing diabetes and heart disease, etc. But really, when you go back to the general exam, we have to divide it into two things. The first thing about the general exam is cognitive data and gathering of this data, because we're trying to get back to data collection about this person. But the other key element of the GI exam that people are concerned about is what we would call the emotional or the rapport that is generated between the patient and the physician, and the level of trust that is engendered when you touch a patient. There have been many times in Abu Dhabi where I've come across patients who have seen doctors and the doctors never touched the patient or never examined the patient. And in those situations, I found that many of these doctors, many of these patients don't really have a trust. They have no rapport with their doctor, and often they don't follow recommendations. Often in many pictures that we see, of doctors with patients, we see them looking at each other, talking, non-verbal communication, and feeling this touch thing is very, very important. Sitting, discussing in a dialogue form of way. But let's go to a little bit of data now. When we're looking at, for example, when we're talking about gastroenterology, first of all, let's talk about the kind of diseases that we have. Not all patients that come into the clinic have an ulcer or cancer or inflammatory bowel disease or a papillary stenosis. No, 40% of them, according to the World Gastroenterology Organization in 2020, with Eamon Quigley down here, 40 of them, around 49% of females and 36% of males in thousands and thousands of patients that they evaluated around the world, met at least one criteria for functional GI disease. It was common throughout the world, with the most common functional disease, meaning no discernible structural or organic pathology, functional constipation followed by dyspepsia, proctalgia, Fujax, functional diarrhea, and irritable bowel syndrome was there at 4%. Interestingly, this was twice the normal irritable bowel cell prevalence than all the IBS societies had put together. This is a very busy slide, but it's to tell you the history of the physical examination throughout human history. You may read many books, and they always start here with the Greeks. They say the Greeks found the four humors: blood, phlegm, yellow bile, and black bile. But this is absolutely rubbish. The Greeks didn't do anything. It was the Indians, my friend, that found most things in healthcare. From the Vedic period, 1,500 to 600 years before Christ, from the Atharva Veda, they used to use herbs, water, soil, milk, many things, and they used to begin that they could be the arrangement of these four humors, seasonal changes, infections, etc. And they began to examine patients many years before the Greeks. And then came Ayurvedic medicine. Many of the Indians in the audience will be familiar with Ayurvedic medicine, which started 600 years before Christ. Three humors, wind, bile, and phlegm, from these sources, and they actually based their diagnosis on examination, reasoning, etc. Interesting, Ayurvedic doctors were licensed by their state. You couldn't go out and be a quack doctor. It was a highly regulated thing. Then came the Greeks, and they moved it from 3 humors to 4 humors. And then we have, like what most people in medical school remember, Hippocrates, the Hippocratic oath. Interestingly, at the time of Hippocrates described clubbing of the fingers, which he associated with a chronic lung disease and heart disease. And the Greeks often used herbs, music, appealing to the gods, and the 4 humors. It was only in the time really in Galen that they began to check the pulse carefully and body temperature. They examined bodily wastes, again, for humoral imbalance, a stool. They looked at facial expression. Now we move a little bit ahead here to these green areas here. You can see that physical examination really came into itself in 1761 when percussion was invented by Albruja, okay? And then later on, by Lennox in 1816 with the stethoscope. This led to significant advances in the way that a doctor sitting in front of a patient could begin to examine a patient. And in the 19th century, and also earlier in the 16th and the 13th century, cadaveric dissection and being able to open up the body allowed us to get to this very key area where we were able to understand what connect disease to the body. In other words, from a synonym, we could have a classification of disease and an anatomic localization of the disease through physical examination. Then we move ahead to things in the late 19th century, the sphygmomanometer for blood pressure, ophthalmoscope, 1850, thermometer, and the reflex hammer. These are all in the 18th to 19th century. But my friends, things have moved on. Obviously, with Schindler in 1932 was the flexible first gastroscope invented. Then came ultrasound in 1956, CT scan in 1967, MRI in 1977, medical AI in 1977 in Dartmouth, USA. When the advent of all of these comes, it starts to reduce the need for doctors to consider doing physical examination, because all of these are interrogating the body in a different way. So new technologies and data change paradigms of the ways of seeing. So luminal endoscopy with Schindler transformed gastroenterology, which was before only done by barium, enema, and clinical history, and like saying, and a bit of radiology. When endoscopy came, it opened up a completely new world for doctors and luminal gastroenterologists as opposed to composite gastroenterologists. Capsule endoscopy is another example of a technology which substantially changed the way that we looked at the bowel. In the 1970s and the early 80s, before Paul Swain and Gabriel Veron invented the capsule endoscope in his garage in London, people used to talk about GI disease being the esophagus, the stomach, and the colon. The bit 5 meters of bowel that was in between was completely ignored, only by barium, a little bit of barium, double contrast barium enema. When capsule came along, it started to look at all the causes of bleeding, tumors, inflammatory bowel disease, allowing much better characterization and treatment of our patients. Then EUS has been another game changer in the way that gastroenterologists have new eyes. And then more recently, high throughput sequencing has allowed us to look at our genome. But remember, not everything that can be measured is important, and not everything that is important can be measured. Now, when we look at the body, this is the capsule issue here. We have all of these things, and you can see that capsule was the game changer in the evaluation of the small bowel. There is no way that a doctor can examine the small bowel with his hands or her hands. It's impossible. I mean, unless there's a big tumor. But with different forms of technology, you can interrogate. And if you go back to the fact that data is the key thing that you want, then you might say, well, why is there a need for a physical examination? On the other hand, what is teleconsultation? You guys are already really used to this idea of a doctor here or a healthcare practitioner and a patient, and they talk like this in real time. But it's much more complicated than that. It's more to do with teleconsultation is telemedicine is only the remote delivery of healthcare, but it is a subset of telehealth. And telehealth, my friends, is many different things. It is synchronous, like you saw when the doctor and the patient are communicating by computer or telephone. It can be asynchronous when data is sent to the doctor or the healthcare practitioners later. Or it can, in fact, include remote patient monitoring, where you're wearing devices which are then translated by the internet to the healthcare practitioner. Now, this is more like a kind of new kind of way that we should be looking at teleconsultation, where the doctor's there, the patient's there. You might see some endoscopic image from a capsule. You may see other biometrics or data. Recently, in the Journal of Gastroenterology, they did ask, during the corona time in 2020, is physical examination useful in the gastroenterology clinic? And they looked at 191 patients, and of those, 121 had physical examination. And their conclusion was that around 20% of the patients, 20% of the patients had clinically significant findings on physical exam, which were missed because of the teleconsultation. So they were a little bit worried, and they said, telemedicine presents a particular challenges and risks to a small set of sub-patients when they have that. This is gastroenterology in 2020 from Eamon Quigley. 73,000 adults, more than 40% had functional GI diseases. And recently, gastroenterology in 2022, clinical gastroenterology, did an update on telemedicine. We're nearly finished. This is the question: is telehealth as clinically effective as in-person? The bottom line is that many people have smartphones and computer access, but 10% were unable to connect to video visits. However, some examples showed, like a VA example, showed that when hepatocellular carcinoma surveillance was done face-to-face and through teleconsultation, more HCC was picked up on a face-to-face examination, involving face-to-face examination, than during teleconsultation. And interestingly, that said that even though it was effective, it was better to have face-to-face. This is another thing that they said. They said, well, if we have telehealth, how can we improve the situation? We can probably identify certain scenarios where the patients need to be physically examined and tease these ones out to come to the clinic, but the others can be done telehealth. Other people have said that we can try to have some nurse or other healthcare worker with at the home of the patient when the physician is taking the history. Telehealth is very useful and it can be used in certain diseases, but most all, and in the limited research of telehealth and gastroenterology, it's most often been used in inflammatory bowel disease and non-alcoholic fatty liver disease using mHealth applications, personal fitness trackers, live video, etc. And often the feasibility, acceptability, and promise in these limited diseases is very helpful. Lastly, we know that when telehealth can be incorporated into diseases like inflammatory bowel disease, and because we can do things like fecal calprotectin, etc. And some studies in gastroenterology have shown that there can be cost savings when you do that. I'm not going to go into all the details because we've covered many of these. Time is running out, but convenience, advantages, cost-effective, good for rural areas or low-income, difficult to access places, protection of the healthcare in COVID, pandemic, coordination of care. But some of the disadvantages are the lack of physical exam, privacy, data security issues, lack of rapport, reimbursement issues, decreased physician satisfaction. In fact, recently in JAMA, a doctor wrote the disappearance of the exam. The role of the physical exam is as a ritual to the doctor to establish the power relationship between the doctor and the patient and to establish trust. The exam brings physicians satisfaction that they're doing a good job by seeing and touching the patient. In the Lancet, they said that, there are limited studies of telemedicine. So basically, I want to summarize now, having covered both physical examination and telemedicine, we have a short time. These are the things. Technological innovation with wearables, remote patient monitoring, and data collection means that the added value of the physical examination is definitely diminishing in today's society. The cognitive and the data collecting features of physical examination can often be acquired technologically by wearables or phones or watches or any other things that you put on the patient to collect data at home and be processed with artificial intelligence. Nevertheless, there's limited research currently on the effect on the emotional trust rapport aspect of the physical exam and its importance in the doctor-patient hierarchy. Definitely, my friends, telehealth and specifically teleconsultation is here to stay. Nevertheless, not all doctors like it, as some doctors told me this afternoon. A proportion of doctors prefer face-to-face. Established patients with inflammatory bowel disease or GERD who are seeing a doctor that they know, don't mind it for the convenience. That we know. Teleconsultations are easier in the younger people, but at the end of the day, in the era of AI and wearables, which will be taking over and be a game changer in gastroenterology, the role of the physical examination has diminished significantly. Nevertheless, the value of human touch, presence, and being with the patient can sometimes be some of the most important things in a doctor-patient therapeutic relationship in those patients with functional GI disease. Thank you.
Thank you, Dr. Nigel. Stressing the importance of physical examination in teleconsultations. I think we can take 2 questions. Seems no questions.
Yeah, I will ask one question.
Yes.
Thank you, Dr. Nigel, for this presentation. I would like to ask you one question, Dr. Nigel.
Yes.
So actually, it's not a question, it's a matter of statement. Now we need, as physicians, as specialists, to follow up the technology and innovation and our specialty. But you are right, it's very important. Physical examination is one of the most important, and the history with the patient is one of the best tools to diagnose and to reach as much as you can the best treatment and diagnosis in patients. Now, in such patients, which, as you mentioned, which they are diagnosed already and on follow-up, yes, I agree. But we need to understand there are a lot of things which can be missed on a telecommunication consultation, and it's also medical legal, I can say, and it's a matter of time just to see and to wait to see the results. How is it? Thank you very much.
Yes, I think that I think you're right that, you know, currently with our current setup, without all the ability to see things and to ask and to see where the patient is in their localization, being next to you, this idea of touch, this idea of seeing patients on a regular basis engenders what we call rapport, or, you know, communication or trust between you and the patient. You know as well as I that there are many patients in Dubai who go to see other doctors, you know, are unsatisfied with them, dissatisfied with them, and they come to you, you establish a rapport with them on a face-to-face basis. That patient will stay with you, Habibi, until the rest of your life, isn't it? They come back to you. Why do they come back? Because they trust you, okay? It's very difficult to engender trust on a teleconsultation, because it's a little bit like, you know, there is no, the lack of the humanness transmits. I mean, it's a very different thing if we meet as friends here, and if we have a GI conference which is fully online. It's a completely different experience. And I think that's where the difference lies. At the moment, we haven't really moved fully ahead with teleconsultation, but the payers, the people that pay the money, would like us to do more and more of that because it's less expensive to them.
Dr. Nigel, thank you very much. I have one question. So the technology here is to stay, is not going. So how are we going to balance between, you know, seeing patients in person in clinic and with the telemedicine?
So the question is, like, how can you balance seeing patients in the clinic and how can you balance seeing patients in telemedicine? Well, if your organization or the future in the next 5 years starts telling us that we need to see more patients in teleconsultation, you're first going to be picking the patients with the chronic diseases who you know very well. For example, if you had a patient with inflammatory bowel disease, in some clinics, you're able to do fecal calprotectin at home on a point of care test, okay? You see the patient, you already known the patient because you've scoped the patient before. You can get parameters like blood pressure, points of care CRP, points of care calprotectin. So in that way, you can have a meaningful discussion and treatment plan with the patient. On the other hand, if the patient is either older or with less cognitive ability or less technical ability to like manage the consultation, and it's a new patient, perhaps those patients, especially if you don't feel that the disease is functional, you know, like a benign disease, then perhaps the first consultation should be a physical face-to-face consultation, and perhaps subsequent consultations could be teleconsultation.
Thank you very much.